Okay. Hey everyone. Thanks for joining the chat. I'm Peter Birks. I'm a relatively new nephrology grad, and I've started a position out in Fraser Health, mostly at Royal Columbian Hospital. I'm also doing my master's through UBC in health administration. I am talking to you guys about microscopic hematuria. I did recently work on the BC Guideline Committee to update the microscopic hematuria BC guideline as well. So some of the information will come from there. Oh, I can't change the slide. There we go. Oh, no. Trying to go to the next slide here. So Donnie, do you know why this isn't working?
All right. Give it a try now.
So
open the slideshow button on the
right.
bottom, and then open the slideshow to the right, and then next to comments there should be one that looks like a little box with a black thing next to the Zoom.
All I see is chat, record, breakout room, and reactions.
Oh, okay. What about now?
Same.
Okay, hold on. I'm just going to reset this. Okay, give it a try now.
So yeah, the things that are at the bottom are invite, manage participant, share screen, chat, record, breakout room, and reaction.
Huh. Sorry. That's odd because it was working a second ago.
Should I go to view options, show Sidoni's keyboard?
Should allow you to, I'm going to remove control, and I will pause the sharing, stop the sharing. Oh, I think I've got it open in two places. This might be why. Okay, and okay, I've tried again with this feature.
So my screen is the same. I'm not sure if it's supposed to be different.
It says waiting for Peter Birks to control your screen.
Okay, let's try this maybe.
Okay, I can try to click through for you.
Okay, sure.
Yeah.
So you can go to the next slide. So yeah, I have no disclosures. Next one. So some of the objectives is we're going to define microscopic hematuria. We're going to talk about urine testing and when you should send different types of tests. We're going to talk about an approach and etiology of microscopic hematuria and go a bit more in depth into some causes, some nephrologic causes. And we're going to discuss some indications for specialist referral, which is mainly going to be urology or nephrology. Next slide, please. So this is just what I was saying earlier is we're working on the update of this BC guideline. that was initially done in 2009 and is currently under external review. The guideline is complete. There's quite a few changes to it compared to the 2009 iteration. Next slide, please. These are just the group members involved in that guideline that I just wanted to acknowledge. Everyone from nephrology to ID, urology, primary care, and emergency, and medical microbiology, of course. Next slide. So just as a bit of background, microscopic hematuria is common, quite a big range there depending on where this has been looked at and what studies. It can often be incidentally discovered, but can be associated with urologic malignancy in many cases, so 10% of cases. But certain patients, such as males, for example, have a much higher risk of having a urologic disease requiring intervention or malignancy. And they can also be associated with primary nephrologic diseases and kind of renal parenchymal diseases as well. Next slide. Go to the next, oh, there we go. Oh, back one more. Forward. Should be one, I think, in between. Oh, no. Is that the next one? Yes, you're right. Sorry, it was the one with the definition of microscopic hematuria. So the strict definition of microscopic hematuria is greater than or equal to 3 red blood cells per high-powered field on microscopy. So we're trying to align the lab reporting across BC to reflect this. So instead of saying the like 1 to 5, 5 to 10 thing, it'll say, you know, whether it's 0, 2 or less, or 3 or more, essentially. And significant microscopic hematuria is at least 3 red blood cells per high-powered field on the microscopy. Next slide, please. So with respect to urine testing, this includes urinalysis, which can be both the macroscopic urinalysis, which is the dipstick, or the urine microscopy. The dipstick's often done, you know, at point of care in the office, whereas microscopy is typically done in the lab and is a bit more labor intensive. Dipstick is cheaper as well. So you get sort of different information from each. The important thing is proper collection of urine samples. So it should be midstream specimen in a clean container without prior cleansing of genitalia. For the dipstick itself, it picks up a number of things, one of which is blood. But what it's actually picking up is heme. So not the blood cells itself, but hemoglobin. But it can also be false positive with myoglobin. For example, if someone had muscle breakdown or rhabdomyolysis. Semen can give a false positive or very high urine pH. It is a sensitive test, which means it's a good rule-out test. If there is true microscopic hematuria, a negative dipstick should rule that out. But it's not specific, as we said, because there's a number of things that can cause a false positive, so it needs to be confirmed with microscopy. Next slide. So urine microscopy actually looks at the cells, can look for casts and crystals, and it can look at the appearance of the cells, which is important at telling what's the cause of the microscopic hematuria. You may have heard terms isomorphic versus dysmorphic hematuria, which we'll talk a little bit more about. Microscopy is generally not needed as an initial screening. Usually you first get the dipstick, and if that's negative, there's really no reason to pursue microscopy for the purpose of microscopic hematuria. But if the dip is positive, then this would be the confirmatory test. Next slide, please. This is just showing a bit more in depth the different things you get on both dipstick and microscopy, and under microscopy, what the different findings can be associated with. And red blood cells, we'll talk about all the different things that can cause that in additional slides, but that includes urinary tract infection, glomerular bleeding, or really bleeding from anywhere else along the urinary tract. Whereas red blood cell casts, you'll see a few down under microscopy, are much more pathognomonic of glomerular nephritis, as are dysmorphic red blood cells. Next slide, please. So this is just showing a picture of the dysmorphic red blood cells on the left. You can see they don't have that normal circular appearance. They kind of are blebbed and misshapen as they are squeezed through the glomerulus and through the tubules and the nephron. They get exposed to both mechanical and osmotic pressure, which can misshape them. The ones with the little blebs are called acanthocytes, and those are very specific for glomerular hematuria. And then to the right, that's a red blood cell cast. So it's a number of red blood cells have kind of clumped together as they've passed through the nephron tubules, and you see these red RBC casts in the urine. Those are rare, but when we do see them, they're very suggestive. Even though when you order microscopy from the outpatient labs, theoretically you should get this information, it's not necessarily reliable. Like often myself, I'll actually look at the urine myself. They'll tell you if there's red blood cells, but it's pretty rare they're actually going to report on the dysmorphic hematuria. Next slide, please. So this is the general approach, which I'll have a pictorial kind of representation on the next slide. But firstly, you can have mimics of microscopic hematuria, which could be bleeding from other places outside the urinary tract, like menstrual bleeding, and also sort of drugs like rifampin or foods like beets that can cause red urine can sometimes cause a false positive for macroscopic hematuria. But the microscopy, of course, in those cases should be negative. Systemic causes, so severe coagulopathy can theoretically cause microscopic hematuria, but it's pretty rare for that alone to be the case. Usually there's also some underlying reason within the urinary system for that, essentially that coagulopathy is unmasked. There's renal causes, and basically anywhere along the tract, so kidney to ureter to bladder to the bladder, neck, and the prostate in males, and then the urethra. So next slide. This is a kind of pictorial representation of the same thing from UpToDate that shows some of the causes. So within the kidney, there's renal masses, both benign and malignant. There's, of course, glomerular disease, other structural disease such as polycystic kidney disease, medullary sponge kidney infections like pyelo, malignant hypertension can do this, papillary necrosis, which can be in sickle cell disease or sometimes in diabetes. Within the ureter, of course, any mechanical obstruction, malignancy, stones or strictures, post-instrumentation or surgery. And then within the bladder, cystitis, infection, radiation, malignancy, and so on as you go through the system. So it's always good to think anatomically. And sometimes, like, classically they say, the appearance of the urine can be helpful. For example, if it's, sort of this darker kind of brownish Coca-Cola color, that may be suggestive of a nephrologic cause or glomerular cause, because that blood's had to transit quite some time and it becomes that appearance. Whereas, more pink blood with clots may be suggestive more of a lesion in the ureter or bladder. I would say those are good rules to think of, but are not necessarily completely reliable. It would be rare to see clots for sure in glomerular bleeding, though. And the timing of the blood, if there's pee throughout, it suggests maybe higher up, where pee just at the end of micturition, or so blood at the end of micturition may more be suggestive of a bladder or neck issue. Okay, next slide, please. So I just wanted to quickly talk about screening. This is something we kind of discussed ad nauseum in our guideline meeting, along with Chris, the urologist in the group. And based on the most recent American Urology Association guidelines, general population screening doesn't have enough evidence to be recommended for everyone. But certainly higher risk individuals can be screened with a urine dip for microscopic hematuria, so that you don't miss a lesion or a sort of treatable cancer. In general, we're talking about a pretty loose definition of high risk, though. People sort of above the age of 40 generally meet criteria. I'll go more into that. One of the big changes now is that urine cytology is not recommended routinely for workup of microscopic hematuria. So that would be something that has been sent off a lot, that we, based on our most recent guideline, are not recommending that people do. Because essentially these people, if they do have microscopic hematuria, it's not going to be, or you're not going to reliably rule out a malignancy by urine cytology, and these people are probably going to end up needing like cystoscopy anyways. Positive urine dipstick should prompt microscopy. We've talked about that before, and significant microscopic hematuria does require further workup. We go to the next slide. So I'll show you the whole algorithm in a few slides, but in general, when you detect microscopic hematuria on a dip, you should think about reversible causes of bleeding, such as infection, UTI, menstrual bleeding. Vigorous exercise can cause microscopic hematuria, or trauma from instrumentation, even sexual activity, prostate exam, viral illness, a number of things. So if any of those could be present, you want to see if you can sort of address the underlying cause and then repeat the dipstick. If it's persistent on repeat, that's when you should send microscopy off for confirmation. And all patients with confirmed microscopic hematuria generally should have imaging done with a kidney bladder ultrasound. You know, in our guideline discussion with Dr. Hogue from urology, he thought that maybe CT shouldn't actually be the first workup unless patients are very high risk, because often we're not even ordering the correct CT to rule out urologic malignancy, and he'll end up ordering a new one anyways. Whereas the bladder ultrasound is a good screening test, which is of course inexpensive and safe with respect to radiation exposure. Next slide, please. So a bit more information about renal imaging. The ultrasound should reliably detect masses that are bigger than 3 centimeters, hydronephrosis, but of course it can miss very small masses or stones. The IVP test is generally not used anymore, whereas for better delineation of masses, CT IVP is the best test, but that can often be ordered by the urologist after referral. A non-contrast CT-KUB or single-phase CT are actually not adequate for investigation to completely rule out a malignancy. So as we said, let's ultrasound first. If you have a really high suspicion of stones or malignancy despite the negative ultrasound, you could order the CT IVP. Next slide. So I'm going to talk a little bit about referral criteria and reasons to consider sort of renal or urology referral. So really, nephro should be involved if there's findings concerning for renal parenchymal disease, so low kidney, in association with the microscopic hematuria. So low kidney function, proteinuria with microscopic hematuria would be quite suggestive of glomerular disease. RBC CAS and dysmorphic red blood cells, which we talked about. Other urine sediment, like sterile, like white blood cells in the urine without infection, can be suggestive of an interstitial nephritis, and that can also cause microscopic hematuria. And then some clinical features. These aren't like you have to refer every patient to nephrology if they have these things, but might increase your suspicion of underlying renal parenchymal disease. So if they've had a recent upper respiratory tract infection or pharyngitis, those can be associated with glomerular disease and often trigger the hematuria in people with underlying diseases. A family history of polycystic kidney disease, that stands for autosomal dominant polycystic kidney disease, or Alport disease in the family. Should sort of spur a nephro referral. Next slide. And then for urology referral, and the caveat is I'm not a urologist, but you know, with respect to microscopic hematuria, this is important. All patients with microscopic hematuria and age greater than 40 should be referred for a urologic assessment. I'm not sure if, I think we should be on the next slide. I don't know if there's just a bit of a delay changing it there. Patients with positive imaging findings on the ultrasound, unexplained persistent microscopic hematuria, or patients with risk factors for urothelial cancer, which I'll show a table of. So next slide. So these are kind of the risk factors, age being a big one, male gender, 2 to 3 times more likely to have urothelial cancer. Ethnicity, environmental exposures, smoking being the most important, but also some occupational exposures and radiation exposure. And then urologic history. So if they've had gross hematuria, if they've had chronic inflammation from indwelling catheters, because that's going to cause higher cell turnover and risk of malignancy. And And I mentioned schistosomiasis at the bottom, which is quite rare in North America, but it's important to take a travel history. Okay, next slide. This is just to highlight that smoking is the most important risk factor. And next one after that. So generally these patients are going to end up requiring cystoscopy because, you know, imaging is important, but it's not going to be perfect at assessing the lower urinary tract. So patients who have these risk factors are generally going to undergo cystoscopic evaluation. Next slide. So this shows our algorithm that's from the guideline under review, and it basically goes over what we just said. This kind of sums it all up. So you do a dip, you check for reversible causes, treat them, then retest, and if it's persistent, you do the microscopy to confirm. And once you've confirmed there's 3 or more cells, you do imaging, and after that, you can, you know, if there's age greater than 40, any risk factors or any imaging abnormalities, sent to urology. If there's any findings supportive of renal parenchymal disease, like abnormal renal function, proteinuria, CAS, or so on, refer to nephrology. And if you don't meet criteria for referral to either, then you can continue to monitor and screen with microscopy and renal function every 6 and 12 months and annually thereafter. If the workup's negative, I'll address that on the next slide, like if the microscopic hematuria eventually clears. And then if there's actually a positive dip, but less than 3 red blood cells on the microscopy, you can continue just to monitor. You don't need to refer at that point because that's not considered significant microscopic hematuria. Next slide. So if there is a negative workup, as I said before, recheck the following parameters at 6 and 12 months along with the urine microscopy to see if there's any evidence they're developing signs of a renal disease. But if you have 2 consecutive annual urine microscopies that are negative, you can then stop screening at that point. Okay, next slide. So we're going to talk a little bit about some of the renal parenchymal diseases that can be associated with microscopic hematuria. The first one being glomerular nephritis. And essentially in this disease, you have injury or inflammation within the small capillaries in the glomerulus. And because of that, red blood cells are sort of leaking through the barrier that's normally intact and getting into the urine along with protein as well. And because you're damaging those filtering units, your kidney function can also go down. Then there's one called thin basement membrane disease, which actually is a glomerular disease, but it's a very common genetic disease that sort of causes, for the most part, benign microscopic hematuria. It ends up being a large proportion of the patients we see in nephrology who are referred for hematuria. Alport syndrome, which I'll talk a little bit more about. Acute interstitial nephritis, which can be associated with drugs or infection or a number of other etiologies. They usually have some white blood cells in their urine too. Polycystic kidney disease, which is actually the 4th most common cause of CKD in BC. Sickle cell in our patients with African descent can cause microscopic hematuria. So if you have the right patient background, that's something to consider. And then there's other rare causes like something called loin pain, hematuria syndrome, and nutcracker syndrome. And these are mostly diagnosis of exclusion. Nutcracker is when you essentially get compression of your renal vein between the aorta and the superior mesenteric artery, and it increases pressure in that vein and leads to bleeding. And then loin pain hematuria syndrome is typically in young women who have pain and episodic hematuria. It's not well described, but typically they have bleeding from some cause, often thin basement membrane, that then clogs up the tubules and increases the pressure in the kidney, causes capsular stretch is the theory, which then causes pain. But those are kind of diagnoses of exclusion for the most part, as I said. So next slide. So glomerular nephritis. So the terminology can be confusing. So glomerular disease is more of a catch-all for any inherited or acquired disease that affects the glomerulus, which is the first filtrating unit of the nephron, where it's made up of these small capillaries where the blood will enter. And then there's a number of barriers, including the endothelial layer of those capillaries. And outside those, there's a basement membrane made of collagen and other proteins and constituents. Then outside that second barrier, there's a third barrier, which are these specialized cells called podocytes with these long foot processes that kind of wrap around the basement membrane. So for something to get from the blood into the urine, it needs to basically pass through all of those layers, and typically red blood cells will not. Glomerular nephritis is more suggestive of inflammation in the glomerulus. So glomerular disease typically presents with some combination of proteinuria, hematuria, or change in kidney function, and it can have one or all of the above. Classically, we learn about the nephritic and nephrotic syndrome spectrums, and different diseases can present on different parts of that spectrum, so it's helpful for diagnosis. But not every type of glomerular disease is going to cause a rip-roaring nephritic or nephrotic syndrome, but it's a good way of kind of at least framing things clinically. So next slide. And this is just a brief overview to refresh. The nephritic syndrome is associated with hematuria and the dysmorphic cells. Usually involves some inflammation in those capillaries and surrounding areas. It causes renal insufficiency, low urine output, and often associated with hypertension. They do get proteinuria, but it's usually not as much as the nephrotic syndrome, which you can see the criteria to the right. More nephrotic range proteinuria associated with the edema and the low albumin, and so on. So nephrotic syndrome typically has no hematuria, but rarely can, because you're still disrupting the glomerulus, and there still is a chance blood can get through, but it's not a typical component. However, even patients with minimal change disease or diabetic nephropathy can get a bit of blood in there, but it's not a sort of a typical finding. Next slide. Just showing this again, so this would be suggestive of glomerular bleeding, these dysmorphic red blood cells that have been squeezed through the nephron, and then these RBC casts, but we don't see those all the time. So they're specific tests, as in they rule in well, but they're not necessarily sensitive, so they don't rule out glomerular disease by virtue of not having these. Like, you can have red blood cells that don't look like this, and it can still be glomerular disease. Next slide, please. So just going through our categories again, these are some of the causes of nephritic and nephrotic syndrome, and there can be some overlap as well. So for nephritic, we're thinking things like IgA nephropathy, which I'll talk about, which is along a continuum with Henlock, Scholl, and Purpura as well. ANCA vasculitis, like GPA, or previously called Wagner's disease, EGPA, or previously known as Churg-Strauss, anti-GBM disease, good pastures, which can often have sort of the pulmonary involvement too, lupus, of course, and then post-infectious glomerular nephritis, which can be related to classically strep, but also staph infections. Endocarditis can cause an immune complex disease that deposits in the kidney, causing a GN. And then nephrotic syndrome is more associated with, the high protein, not as much the blood, but minimal change disease, focal segmental glomerular sclerosis, membranous disease, diabetes, amyloid. And then you have these diseases that typically kind of fall in the middle and can cause either. So membranoproliferative GN being one of them, IgA nephropathy can kind of present like any of these different pictures. Next slide. So when you do have a patient who is presenting with the GN picture, you have to think about sort of what tests you'd send off, and often this will be after referral to nephrology, but I think it's worth talking about. Often GNs can be associated with underlying causes, secondary causes like malignancy or autoimmune conditions, infections, or drugs. I always remember the mnemonic MAID myself, M-A-I-D, so malignancy, autoimmune, infection, drugs, whenever I see a patient with signs of glomerular disease. This is kind of the panel I usually send off for a patient who I'm concerned for, and often a kidney biopsy as well, but this is to screen for some of the causes, infections that are associated with GN, and then lupus, amyloid and myeloma screening, ANCA and good pasture screening, cryoglobulins, which can be associated with a number of things, including hepatitis, autoimmune conditions, and so on. And then blood cultures in the right patient, because as we said, endocarditis can cause a GN. That ASOT is screening for strep antibodies. I variably do that. I don't think that's needed in every case, because this could just be positive if you were exposed, years ago as well. So next slide. I did want to talk about IgA nephropathy a little bit, because this is by far the most common primary GN that we see in our population and in Western and Asian countries. Often patients referred to nephrology. This is what they end up having when they're having the microscopic hematuria and signs of a renal parenchymal disease. So IgA is an immunoglobulin that usually sits in surfaces of like the gut and the lungs, so sort of secretory endothelial surfaces to protect against infection. But in IgA nephropathy, these IgA molecules go a little bit wonky. It's something to do with an abnormal glycosylation of these IgAs that are produced in the bone marrow. And instead of sticking to those surfaces, they end up going into the bloodstream and causing inflammation, particularly in the kidney. So it can present in a number of ways. The most common is just episodic hematuria, and often gross hematuria, but sometimes microscopic. And these are often preceded by infections like upper respiratory tract infections, but also other things like gastroenteritis can stimulate this and so on. So 40 to 50% of IgA cases just present with episodic hematuria. They can also get proteinuria, and in rare cases, they can get a full-blown nephritic or nephrotic syndrome. They can get acute kidney injury, actually, because glomerular bleeding can lead to clogging of the tubules with blood and cause like an acute tubular injury or an ATN. So you can get that actually with episodic bleeding of any cause. And about 25% of patients get CKD. Next slide, please. Prognosis-wise, markers of poor prognosis for IgA are hypertension. So we really pay close attention to that in our IgA patients. Renal impairment, of course. The severity of proteinuria. So if they have more than 1 gram of protein per day, that is a marker of poor prognosis. And the findings on the kidney biopsy. And the picture up to the top, just so you know, is an immunofluorescence stain for IgA. So that's what we see on the immunofluorescence of the kidney biopsy. That's basically a glomerulus that we've stained IgA, and it's glowing. And then signs of good prognosis are actually the people who just get the recurrent episodes of hematuria. They actually have quite a good prognosis, a low risk of renal impairment in the future. It's just a bit scary, obviously, for the patients when they get an infection and then see blood in their urine. And to touch on proteinuria, usually can check that with a urine albumin to creatinine ratio. And if you want to get an estimate of what their 24-hour urine would be, you can kind of take their ACR, which is in milligrams per millimole, and just multiply that by 10. And that will give you roughly the number of milligrams in a 24-hour urine that patient would have. It's not perfect, but it's helpful. For example, if your ACR is 30 milligrams per millimole, you times that by 10, it's roughly equivalent to 300 milligrams per day of protein, of albumin. So for IgA, we do target lower blood pressures, less than 130/80. We typically try to start renin, angiotensin, aldosterone blockade with either ACE inhibitor or aldosterone receptor blocker or an ARB. And we basically want these patients to have less than 1 gram per day of protein, so or an ACR less than 100 milligrams per millimole, because we know from studies if we can achieve that target, patients do a lot better. So we typically optimize their ACE inhibitor or their ARB to try to achieve that. We don't combine the two, though, because we know from studies that that's associated with higher risk of kidney injury and hyperkalemia. So we either choose an ACE or an ARB and optimize the dose until we can get their protein down and their blood pressure down. There is some weak evidence for using fish oil, so sort of omega-3 ester fatty acids, quite a bit of it. I think it's 3 or 4 grams a day. And there's some observational data that may lead to improved outcomes. And then in severe cases, we use immunosuppression, whether it be steroids or steroid-sparing agents. And that's usually reserved for people with, protein that's not responding to the ACE inhibitor or the ARB, nephrotic syndrome or nephritic syndrome, and so on. But that's sort of, we usually try the ACE inhibitor or the ARB first and then see how they do. We usually do the kidney biopsy, see how severe it looks, and decide on that. And then, of course, kidney transplant's an option if they do reach end-stage renal disease. There's some risk of a recurrence in the transplant, but it's still a good treatment for them. Next slide, please. So thin basement membrane disease is another glomerular disease, which is very common to cause microscopic and sometimes macroscopic hematuria, but mostly microscopic. So this is a familial in most cases, but it can be sporadic, and it's an autosomal dominant inheritance. So often there is a family history. Similar to IgA, the hematuria can be triggered by respiratory tract infections. The onset usually occurs during childhood or adolescence, but some patients, if it's all microscopic, of course, aren't going to have had their urine checked, so it may be diagnosed later in life. And about 20 to 25% of patients referred to nephro for persistent hematuria end up having this diagnosis if they're biopsied. And you can see this is an electron microscopy at the top. And at the bottom is where the endothelial cells are. So that's like the inside of the capillary. And then above that is the glomerular basement membrane, right here. And then these are the little podocyte foot processes. And so this is a normal glomerular basement membrane. And this is beside it one in thin basement membrane disease. And it literally just looks thin. And because of that, sort of blood cells can kind of squeeze their way through. It's usually pretty benign, but it can in rare cases be associated with CKD, hypertension, proteinuria, and so on. So yeah, these patients should still be sort of monitored over time with, urinalysis and ACR and renal function checks periodically. Okay, next slide, please. Alport syndrome is another important one to be aware of. This is also inherited, and it's another inherited disorder of that basement membrane. And it's a mutation involving the type 4 collagen that makes up that basement membrane, but also basement membranes in other areas in the body, like the ears and the eyes and so on. So the presentation is classically nephritis with hematuria, proteinuria, and renal decline, usually sort of in the second, third, fourth decades of life. They also get sensorineural deafness and ocular abnormalities. That's kind of the classic triad. There are other more rare manifestations as well. So there's 3 forms. Most commonly is X-linked. So generally males being the ones with the most affected. Females, if they do have one of those X's, can have some symptoms, but not severe renal failure or anything. When females are affected with severe disease, it's usually the autosomal recessive form, and often no family history because both parents probably just had one allele and weren't affected, and then that female was unfortunately got both of those recessive alleles for the disease and had the full-blown disease. And there's also a rare autosomal dominant form, which interestingly is not actually associated with severe disease. Next slide. So the diagnosis is generally, meeting the clinical syndrome, and then you can do a kidney biopsy to look for some of the classic features of Alport's as well as genetic testing. Unfortunately, these patients do generally progress if they have the full-blown disease, but using RAS blockade can delay that, and they are candidates for kidney transplant. Interestingly, though, because they don't have normal glomerular basement membranes, when you transplant a new kidney into them, they can actually form antibodies to that patient's glomerular basement membrane because their body's not used to that and produces antibodies, and then they can develop anti-GBM or Goodpasture's disease to their new kidney, and that happens in about, I think, maybe 10% of cases. I'd have to check that number actually, but not uncommon. Next slide. Because we're on the topic of hematuria, I did think it would be reasonable to talk a little bit about kidney stones too, because this is common. And I'm going to talk more about the medical side of kidney stones, not the surgical side. I'll let the urologists deal with that. But common, 12% lifetime risk, and if you've had one, you have a high chance of a recurrence. These are the different types of stones: cystine, calcium, uric acid, and struvite being the most common, and then there's other less common types. So next slide. So calcium oxalate stones make up the majority, 75 to 80%. You can also get calcium phosphate stones, struvite stones, which are the ones more common in females and associated with your recurrent UTIs. Cystine stones are generally genetic, and they're rare and very difficult to treat. Uric acid stones, higher in patients with high uric acid levels or gout. And then there's medications like Indinavir stones related with antiretrovirals. And then you can get stones that are kind of a mix of all of the above. Next slide. So some of the risk factors, the urine pH. So uric acid stones like to form in acidic urine. So this is why sometimes we alkalize their urine with bicarb or citrate. Also, low urine citrate or hypocituria is a big risk factor for kidney stones. And this is something we can test on their 24-hour urine. So citrate in the urine actually inhibits stone formation. And some of the things that cause low urine citrate are chronic acidosis, because if the blood is acidic, a lot of the citrate's being used as a buffer in the blood, doesn't get into the urine. And high urine sodium actually can reduce citrate in the urine as well. So that's why we reduce their sodium intake when people have stones. UTIs and instrumentation are risks for struvite stones. A family history of stones is a risk factor. High sucrose and fructose beverages like soda pop increase the risk of stones. So we ask patients who've had stones to cut down on those things. Probably good in general to cut down on those anyway. Vitamin D and C intake. So vitamin C is metabolized to oxalate, so we try to avoid that in patients with stones. And high doses of vitamin D can increase the calcium in the urine, so that can be a risk factor. And then other diseases like inflammatory bowel disease increases the risk of calcium oxalate stones, hyperparathyroidism and sarcoidosis, renal tubular acidosis, polycystic disease, a number of things. Next slide. So treatment of stones, calcium oxalate, as I said, are the most common ones. So increasing fluid intake, trying to get the urine output to 2.5 to 3 liters a day is the best way, because you're just not allowing those stones to precipitate. Often patients will drink a lot of water during the day, but they don't want to be up peeing at night, so they sort of stop drinking at night, and then their urine gets concentrated. So it's a bit of a balance. If they really want to prevent their stones, they may also have to be peeing at night. Adding some lemon to their water will give them some more citrate. So that's a good way to prevent stones. I tell them to drink lots of water and squeeze some lemons in there. Avoid high oxalate. So all the good things in life, tea, chocolate, high amounts of coffee, rhubarb, cranberry juice, and there's a number of other things. Everything in moderation, though. I don't tell them to, remove everything good from their life. There's no role of reducing dietary calcium. So high calcium is actually protective because it will bind some of the oxalate in their gut and prevent them from absorbing the oxalate. So you don't need to have them restrict their calcium intake. Reduce their sodium intake, as we said, and the sucrose and fructose is important. You can use medications, so we can give them potassium citrate to increase the citrate in their urine. Thiazide diuretics in some cases, because that'll cause the calcium, which is in the urine, to move back into the blood, so it reduces the urine calcium. And then, of course, surgery, which can be urology's domain, but anything from lithotripsy to ureteroscopy, percutaneous so percutaneous stone removal as well, depending on sort of the patient, the size of the stones, and the stone burden. Okay, so next slide. To summarize, we define significant microscopic hematuria as 3 or more red blood cells per high-powered field. For urine testing, we screen with dipstick. If that's negative, you're pretty much done. But if it's positive, urine microscopy should be used as a confirmatory test. Should rule out reversible causes such as UTI, menstrual bleeding, and so on, and then retest. And if it's persistent, you should get some imaging, ultrasound being the recommended first-line imaging. And then patients with high risk of urologic disease should be referred to urology, and patients who have findings concerning of renal parenchymal disease should be referred to nephrology. Next slide is my references, and thanks so much for listening to me for the past 45 minutes. Hopefully that was helpful for you guys, and I'm happy to answer any questions or comments. Okay, let's see this chat here.
That Dr. Lyle wants you to come to the kidney clinic at the hospital the next time you see him. Okay.
Pardon me?
Yeah.
I think I missed that question.
Sorry, that there should be in the chat feature. I know there's at least one question in there.
One in there. I don't know if someone else was asking a different question too. Okay, so someone says, what did you say about vitamin C and D? I recently recommended to start a patient on vitamin C to reduce recurrence of Foley catheter UTIs. So yes, vitamin C is one of the biggest risk factors for calcium oxalate stone formation. And unless there's a really good reason to be on that, I would not. Similar with vitamin D, I think a lot of I know this is a debatable topic, but I think a lot of the evidence of like everyone needing to be on vitamin D is, starting to sway maybe the other way, that the benefits, when we've been studying them, might not be as vast for the general population as we think. Certainly people who need to be on vitamin D for, osteoporosis or vitamin D deficiency should be on it, but I don't think giving people like high doses of vitamin D in the absence of a good reason, especially if they have a history of stones, is the best idea. So vitamin C, huge risk factor. Vitamin D does also increase the risk. So you'll have to balance the benefit versus risk there.
Oh, sorry, this one was sent just to me. I'll send it to you.
Line pain hematuria. So, that's a tough one. So it's generally a diagnosis of exclusion. You can rule out, you can investigate nutcracker syndrome with like an MRA to look at the blood vessels. But loin pain hematuria syndrome, at least from my understanding, is generally a diagnosis of exclusion. But you want to look at like why are they having like underlying bleeding that's clogging up those tubules. So that's typically going to be something like thin basement membrane disease, in which case it would have to be nephrology deciding if a kidney biopsy is indicated for her. We don't typically do kidney biopsy if there's just microscopic hematuria in the setting of normal kidney function and no proteinuria though. So it can be a difficult one, and often it's, we say this could be what it is, but we're not 100% sure. But for the nutcracker, you can do some imaging, but I would discuss that along with either nephrology or urology to decide if that's indicated. So I just saw another message from Judith Hammond. Yeah, so basically the question is if a patient's in her 40s and has persistent microscopic hematuria since the 20s, KUB is normal, family history of thin basement membrane disease, suspected but no biopsy, does this person need a cystoscopy? I would ask urology about that. I mean, the chances of it being a significant lesion, if it's been present since the 20s in a female with a family history of thin basement membrane disease, in my mind would be low, but also something you wouldn't want to miss, and may want to just run that one by a urologist, because I'm not 100% sure whether they would do a cysto on that patient or not. Sorry. And generally, I don't biopsy those people to confirm thin basement membrane disease in a setting like that, just because the risk probably outweighs the benefit of finding it, unless she develops proteinuria or a change in kidney function. How much time should elapse between exercise and urinalysis to rule out that the exercise is causing the microscopic hematuria? I would think at least 24 hours, but if the patient could wait 2 days between their exercise and their urinalysis, that would be ideal. Honestly, what I'm telling you is just based on my thoughts and experience, not based on any evidence that I'm aware of for that question. It'd be interesting to see if there was actually any studies that looked at that. Thank you very much for listening.